How are you?
Morning, sir.
Good morning. You seem very lonely.
You know, it's nice and it's quiet. And
I can appreciate that.
oh yeah. I live in a house with 2 ADD people, so it's a little crazy. Sure.
You see good? Yes. Good.
Morning.
That's it.
Yeah.
First, nice spoons.
Right in there.
Good.
It looks like the normal order.
It does.
here a little later. I'm
Sorry?
still the first. I got here a little later than I have been, and I'm still the first one here.
Good morning. That's a fancy belt.
Thanks.
Good morning, sir. Morning. Well, it's not that early.
Yeah.
It may be us. Enjoy.
Morning.
Very busy.
This is ripping this corner down there.
Okay.
Well, there you go. Well, yeah.
You know Markus? He's a dear friend. He's like
Are you attacked or are you?
yeah, he does.
So my official
He's a
appointment
good
is
friend of
actually
mine.
good.
But I used to work in separate.
Yeah, I mean, I'm assistant professor of pizza at
Gotcha.
Yeah.
A little time
I
ago,
get it.
I
I've done
remember
it.
that
Same companies.
Major-
Oh, you really don't? Oh, no, we want you back.
No, hi, it's Mary, darling.
the reason for
Mary.
kids to come out is still
From,
She was
you know,
because
yeah.
No.
yeah, I mean, since I'm a cell specialist,
Turn and burn.
Exactly.
Yeah. I'm riding it out. I got Jim less than 10 years ago.
Okay.
Although,
Have you ever used it?
Yeah.
I am not for eczema. Eczema doesn't work
well,
very well.
as much as you got.
For asthma and stuff like that,
I
I
have
most likely, but it's outside my.
No, that's fine. That's fine. What I'm trying to do is I'm trying to find out who I used to get updates. Dr. Redding, you see it in my contact, but he seems very busy.
Yeah.
Who did you see that?
Ida Ong, I know Immunology.
On?
Oh, yeah.
She's great. So that's someone
I got the option last year. I have 2 kids in college right now.
No, I always had good luck, but I just never knew who to kind of,
Yeah.
you need a touch point.
Yeah.
And just say, what do you need?
Yeah.
Yeah.
So, yeah, of course.
Did you find a parking spot, sir?
Yeah, you know those signs start for tomorrow. You have to read the fine print.
You gotta read them.
Did you park indoors or you got on the street?
Street's full of empty spots.
Is that right in front here?
Not in front, but just some.
I parked right in front. You have to read the sign though. You know it said no parking, but it says starts tomorrow. So. But I do get here at 6:30. Yeah, you get.
2 minutes.
Yeah.
But it's almost like something changed because
There was more
there's
today.
like 10 or 15 different spots.
Is that right? I didn't make the loop. I just came right here. I didn't look. Usually I make the loop several times. watched the game last night. I'm not a big Zag fan. Husky, but yeah, no, for the Northwest. Did you watch it?
Yes, and I'm glad they lost.
They
But I have personal reasons.
Okay. Yeah, there are two big stars at the Crummy game. So, you know,
How do you
Williams Goss.
Sam Bibway and recruit somebody, you know?
Yeah, from Poland.
Yeah,
No,
exactly.
it's amazing.
It's like, okay, that's the Northwest. Okay, no, maybe not.
For 7-foot Polish guys. No, he's been good through the tournament, but last night he couldn't make a bucket.
I'm just saying it's kind of fun. That's all I'm saying.
Yeah, it is. No, they do a great job of recruiting.
Oh, they do?
Of course, Williams Goss, who's the most valuable player in his league, was a Husky and he transferred. He was miffed at the program, so anyhow, that's why Romar is one of the reasons Romar is gone. Yeah. But he lost that great recruit, Nathan Hale.
No kidding.
Gosh, you almost had to. It's a principle thing. Here, they bring on their father as a coach. That's a little nepotism there.
Yeah, so.
They had to. So the kid went to Missouri.
So you thought somebody noticed?
Yeah, right. They couldn't hide it.
That's my problem with basketball. Is the kids, they're there for 2 years.
Oh, 2 years. It's one and done. Most of these guys, you're right. That's one thing about Gonzaga. They keep their guys because they don't get the superstars. They're the guys that are one and done, and they stick around. And hey, there's 5 years for the Polish guy. He's about 45 years old. Yeah, he got an extra year because he had an injury.
I
think Oregon.
feeling like more and more.
Okay.
Yeah, they're looking awfully good. I know. Yeah, no, I agree.
And there's another one that I have a problem with.
Yeah, me too.
Bucks game.
Yeah.
I didn't watch it.
You didn't watch it?
No, I was watching America.
Yeah, they didn't do so hot either. Felix, and he's hurt. Did they say he's hurt already?
Yeah, that's what I think too. I'm just gonna
It's going to be another long season. There goes the zero. Yeah. It wasn't much to watch. Well, they hit him. They only had 3 hits.
Just had it on in the background.
Yeah.
They had 3 hits, so no pitcher's going to win if you don't score any runs. They got 0.
Oh, thanks.
I don't know the Houston. I didn't even see the Houston pitcher, but he must be pretty good. Oh, is he? Yeah. I hope that's all that is. Yeah.
Come on,
Lemon's minus.
I was wondering what it
Have you talked to Steve?
Yeah.
Steve
probably not the last one.
He's the one that showed up on
Okay.
He knows more than anyone else in our division about that. So maybe he's been out the last week. He's been sick, but he has his games at hand. So I can start more.
I got a call from my partner from down south, San Francisco. Problems with
Yeah.
Everybody does.
well, they're the worst. It's really the worst.
Yeah. Are you?
I don't know.
I don't know. We dropped them for a while because we were taking money.
Right.
But then because Kevin sees some kids that are mean, we pick them back up, but it's a lost leader. Say maybe 40%, which they're bad.
And all of a sudden say,
Yeah. No more. That's right. Cut me out.
okay, but you've not heard him.
I haven't heard him. Usually I don't know why.
Yeah,
When you start working at the American, when it's not first home.
No, I usually hear something about that. And I haven't.
Where are you moving to?
So I'll follow one chain.
Steve, yeah, Steve, he knows more than I do.
Downsizing.
I think that maybe knows
Really
that
bad.
it's that they haven't understood what's
So,
going on.
yeah, I haven't heard anything about that.
Like I said, I only heard it, I'm gonna say stepwise from, my partner down south. But it's just,
I couldn't move. I got to buy a house and then I got to waste it myself. There's no way. I'm a collector.
I'm
a hoarder, not quite a hoarder, but
I'll let you know if I can.
boxes.
I got tons of stuff. My house like a museum. It's impossible to clean cut junk from trips and everything. And I never throw away a book.
I mean, in my
I
mind,
keep on going and say, why should I wear those books? You're never going to read them. I can't. They're like my friends. I make kids.
Well, you know this, what I'm doing.
Swanson's got food allergy this week.
Is that your dog?
Come early.
But he's down in California, standing out of the corner. So the hot part of the sun.
Oh, is that
Like waking up at like 7:30. Sometimes texted me like, "Where are you?" I was like, "Is this a joke?"
Tons of start.
Hey Jake, tons of start.
Where's my next? Where's my
You don't need to be there until a little after 8. It's in the same place.
I can do that after 8. What time? Tell me.
No, we get there just a little bit before 8.
hello, sir. How are you? Good to you too.
How you been?
Good.
What's Children's Street?
Great. Yes. It'll be 2 years in July.
Oh, you guys doing Immunology?
Jerry, you haven't had anybody homes over there get recurring shingles.
So again?
You haven't had anybody homes recurring shingles? Yeah, I just wanted to make sure.
But it's just a very, like I'm just there.
Oh, because she never heard
Yeah. I mean, for me, it's really cool. No, one of my friends.
So, I don't know what
I find
I've never seen that.
if you put some of the cost of it, what
I know, I mean, I can look at it, just wondered if anybody had seen it. No,
not to my knowledge.
I was just gonna ask, this collective body.
Oh, I know.
I can tell you, I got zero of those rashes. I think you got flu.
I think it's things happening.
Right, that's right. My dad had shingles 3 times. He wasn't on shoulder.
But did he have a vaccine?
No.
Not any changes.
Have you gotten the vaccine? I haven't gotten it.
I've gotten everything. Trust me.
Already. I mean, I'm just
I haven't got my little cough.
Oh yeah.
Yeah, it's stuff with that.
How's that work for you?
Grandchild.
now that Valtrex is generic, the insurance companies aren't quite as nasty.
Anywhere.
Any cycle rate has a dose of like 5 times a day. So, I told her to try some D-Zig if she keeps getting it. No, I feel bad. She has a judge
Not
in
going
there.
anywhere.
Everything good?
Retired, and now she gets shingles and just post-traumatic neuralgia.
How old is she?
64.
All right, Len's out of town, so get started.
That's right.
Word of the day is dermatologic. Dermatologic. Today we have Markus from the Department of Dermatology at Seattle Children's, who's going to be talking to us about dermatologic manifestations of immunodeficiencies. And they actually run a dual clinic of immunology over at Seattle Children's. And there's some great slides here. So, thank you, Markus.
Thank you. Hi, everyone. It's nice to be back. So after last year when I came to talk about how we approach atopic dermatitis, Len was like, "Don't come back and talk next year." So fortunately, I didn't make too bad an impression, but I really appreciate the opportunity to come back. And he said, "How about you talk about the dermatologic manifestations of immunodeficiencies?" And so I said, "Sure." And then as I was preparing the talk, I thought it's kind of a daunting task to speak to a group of allergists and immunologists who are trained in these disorders much more than I am. And so I wanted to make sure that you would get something out of this that was more than just kind of reviewing the inheritance and the genes. And so I really tried to make an effort into looking at the skin manifestations. One thing that I found with Troy and Suzanne and my team over at Children's is that the training that you guys get seems to be a little bit deficient in the differences between the rashes. So a rash is a rash is a rash. I'm hoping that I can at least give you some pearls to help distinguish between things and give you a better sense that when you're looking at some things, you're like, oh, this is more consistent with atopic dermatitis versus Hyper-IgE and whatnot. So, and I'd love for this to be interactive. I learned just as much from you guys as I hope you do from me. So anything you want to add in, chime in, feel free. I don't have any conflicts of interest. So the goals are just to review the presentation as far as the dermatologic features of primary immunodeficiencies, and then review some of the essential elements of treatment that would be relevant to dermatology. So one thing that Troy really likes to deal with is autoimmunity as a manifestation of immunodeficiency. And so complement deficiency is certainly one of these areas where hopefully dermatology can play a role. So with complement, I'm not going to belabor it, but we have the early pathway defects that make the convertases and help with optimization. And when you have issues in complement deficiency early in the pathway, you do have the defective optimization, and we think that that leads to the autoimmune disease because you're not getting rid of the apoptotic debris when cells break down. And what that can lead to is manifestations of systemic lupus. This comes up often in childhood, and they frequently have renal disease, palmoplantar keratoderma, so thickening of the palms and soles, and photosensitivity, which is more marked in C1 and C4 deficiencies. If you have defects later in the pathway, then you're more predisposed to infections with encapsulated bacteria such as Neisseria and also strep pneumonia. And interestingly, the mortality from these and that deficiency is lower, primarily because there's not the cytokine storm that's activated in the same way. So, as I mentioned, one of the manifestations that can come up with complement deficiency is those of systemic lupus. So I thought it would be worthwhile to kind of review some of the things that I see when patients are referred to me to rule out whether this is lupus, and then in the context of immunodeficiency versus not. So what you have up here in the left-hand corner is the classic malar rash of lupus. So this is one that's just sort of a blanchable erythema that's widespread and that has a sort of butterfly distribution across the face. You can see there's some relative sparing of areas that might be sun protected, so a little bit under the nose. Oftentimes the creases here as well don't have quite as much involvement, so those are some different clues for you. And there's not a whole lot of overlying change. Maybe there might be a little bit of desquamation, and some fine epidermal changes, but mostly it's the erythema that you're looking for. Of the other manifestations, or the cutaneous manifestations of lupus, photosensitivity is one of those. That's an objective thing that you just have to ask your patients, do you feel like you're more sensitive to the sun, or that you break out when you're out in the sun? What we have here in the lower left corner are the oral ulcerations that you can see with lupus. So here you can see some on the palate. It's a little bit hard to see the buccal mucosa, but they can be anywhere in the oral cavity. So just seeing any sort of erosions and ulcerations is another clue to the diagnosis. Over here on the right is one of the more severe manifestations of lupus, and this is the vasculopathy that's associated with antiphospholipid antibodies. So what you can see is that what you can see here is that there's almost a net-like appearance to where the redness in the skin comes up. And if you were to press on this, it would be non-blanchable, and that represents the inflammation that occurred within the blood vessels, leading to blood cell extravasation. And again, this, what we consider to be a lividoid appearance, is very common when you have an antiphospholipid antibody type syndrome and the subsequent coagulation of the blood vessels. Down here, you can also see early necrosis of the digits. That's a result of that blood vessel blockage. What I see most commonly in my clinic are manifestations of cutaneous lupus, such as discoid lupus. So these are all pretty classic examples. What you can see up here is there's this erythema, and it typically has an annular appearance to it. And what I hope you can at least tell a little bit from this picture is that there's a palpable component to it. If you press on it, it's definitely raised off the skin. When you touch it, it's a little bit firm, especially along the edges, while the center can be somewhat atrophic. And the other clue that this is a cutaneous lupus is that it has this mottled hyperpigmentation, which is a little bit more evident here when you look at the conchal bulbs. So as far as locations, photodistributed sites, so face is often a common place where we first see manifestations of cutaneous lupus. But the conchal bulbs is another classic area where you'll look for discoid lupus. And again, you can see that there's this dyspigmentation and lots of scaling through here as well. There's this sign called the carp attack sign, where if you were to pluck any of these scales off, you can actually see almost what looks like a little spire of keratin that was plugged in the follicles there. And often discoid lupus can progress to become scarring on the scalp. Again, another very common location to have this. And you'll see the scarring, hair loss, the mottled pigmentation that's both hypo and hyperpigmented, and then these thick scales that are adherent. So with respect to complement deficiency in lupus, the most common complement deficiency that leads to systemic lupus is C2 deficiency. And that's just because C2 deficiency is the most common complement deficiency. The other more proximal complement components, including C1, Q, R, and C2, C4 are more rare, but they are also more likely to give autoimmune disease and the specification of lupus. So these patients, the key to this is that in addition to having all the features of lupus, which might be the reason that I see them, what you might see them for is that they're more prone to infections. But it's a dyad of both of these symptoms that should lead you to suspect that in addition to their lupus or in addition to their complement deficiency, there's something else going on. So from my standpoint, I think of C2 complement deficiency leading to lupus when it's a childhood onset. Of course, I see only children. But the skin lesions are treatment resistant and really recalcitrant, so I can throw whatever I want at them, but things don't seem to get better. In contrast to sort of spontaneous or idiopathic lupus, renal disease and arthralgias are typically more mild, and their ANAs are a little bit lower or absent altogether. They're often antibody positive for Rho, and overall we consider the course of this to be less severe. However, again, they do have the complication of more infections, which is not something that I would typically see in a patient who's just coming de novo with lupus. And atherosclerosis is another one of the side effects we can see with this. And then from an immunology, yeah.
When you say C2 is low, is it low enough to show up on a CH50, or do you have to measure C2 independently?
That is a good question. I don't know the answer to for sure. I think that if you do a CH50 and it comes back normal and you still have that suspicion, then I would check a C2. And in terms of immunologic things, this can also coexist with common variable immunodeficiency as well. So this is a patient that came to see me early in January. It's a patient, Kathy Mohans, that had a sibling who had a known C1q deficiency. And she had seen Kathy before just to kind of make sure that things were on the up and up. Had a few infections, but nothing major. And they came to me for rash. And I see that as the presenting complaint for lots of things. And I was reviewing the referral. It just happened to mention that she also had a C1q deficiency, and I was like, oh, okay, I need to prepare myself for what I'm going to see. And she came in, and sure enough, she had what looked to me very consistent with discoid lupus. So this is exactly the same thing. So you can see the bright erythema, the sort of thicker scale, the erosions to it. And if you pressed on it, it had an indurated quality. So that's not typical of something that I would see, for instance, in atopic dermatitis. And the annular character to it, again, so that you have a little bit of substance, a little bit of thicker scale, and then an annular look to it on the face was really good for discoid lupus. And so I was like, yeah, this is what's going on. And did biopsy her because I'm not crazy about biopsying the face, but there would also be very characteristic looks histologically that would help confirm the diagnosis. So the question is, from my standpoint, what do I do with this? And I rely on you guys to help with the immunologic side effects. Obviously, if there's an infection, I can help treat that. But with respect to the lupus, starting for me, what I use is just topicals. And on the face, I would even use a stronger topical steroid than I would normally would for something like eczema. So going up to triamcinolone or mometasone, so a class 3 or 4 steroid would be completely appropriate as long as you let the parents know about the risks of overuse. I would see them back relatively quickly afterwards, and I switch them to something like a topical calcineurin inhibitor that they could use indefinitely. The other thing that's really important to stress to these families is that because the lupus can be triggered by light, they have to be really vigilant about photoprotection. So staying out of the sun and then using sunscreen, and that's pretty much a fundamental part of treatment for this for any sort of cutaneous lupus. And then avoiding family members who smoke or telling them not to smoke, or if it's an older patient, making sure that they don't smoke because that will exacerbate things as well. As far as systemics, the first line is antimalarials, so things like hydroxychloroquine or plaquenil, and those are, we don't really know how those work. We know they're immunomodulatory and they alter TNF signaling, but it's a little bit hand-wavy why it works, but it seems to work really well for these conditions. So it's sort of like the first couple steps that I would take. Okay, so I'm going to move along to something that's a little bit more, I guess, bread and butter immunology, and talk about the different Hyper-IgE syndromes. So we'll start with autosomal dominant Hyper-IgE with STAT3 mutations. So, the classic appearance for this is dermatitis, abscesses, recurrent sinopulmonary infections. But the distinguishing thing that often comes to me is this atopic dermatitis-like eruption. And the question often comes up when I'm in clinic for children who have really severe atopic dermatitis is, do I need to worry that they have Hyper-IgE syndrome? And I think the key with this is that the look of the dermatitis for autosomal dominant Hyper-IgE syndrome is not the classic atopic dermatitis. So if you remember from my talk last year, when we're talking about infantile atopic dermatitis, it's typically an eczematous eruption that's on the cheeks, and then you have it on the extensor extremities first before it turns into the flexures. But what children with Hyper-IgE syndrome have in infancy is what's defined more as a papulopustular eruption. So they have these crusted papules and pustules that are diffusely across the face, but also within the diaper area and a little bit more wide spread. And these, again, in addition to the appearance, if that's a little bit tricky, the distribution is a clue that it's not just entirely normal atopic dermatitis. And we'll look at some pictures. Other things that I would look at from just a physical standpoint, asking about hyperextensibility, retention of primary teeth, having a high arch palate, and then some coarse faces. And we'll show you some pictures of these in a moment. And then, of course, these patients will typically have increased IgE levels, but again, I think it's important to remember that at birth or early on in life, they may not have elevated IgE levels. So if there's other things that kind of trigger your suspicion, don't let that be, or dissuade you from considering this as a diagnosis. So again, getting back to the question, what does this papulopustular eruption look like? You can see that this child has it really predominantly on the forehead, and certainly there's cheek involvement as well, but it's not the classic, like you look at them and think, oh, you just have atopic dermatitis. And the lesions are a little bit more discrete, so you can kind of see that there's these individual papules, and again, without the color in this picture, it's a little bit hard to see, but they're crusted, they're eroded from the child scratching at them. So this is a look that's a little bit different from typical atopic dermatitis, where you have erythema and scaling, but not quite the same papular component to it. And then again, down here, you can see that involvement is diffuse on the buttocks. And again, that's an area with atopic dermatitis that we don't expect to see because the area is so much more humid that typically the skin there is intact and not affected the same way that other body surfaces might be. This is just an example of cutaneous abscesses. So in children less than 2 years of age, it's very common for them to get them on the scalp. So you can kind of think of it as a folliculitis that might affect anybody. But in these children who have an abnormal immune system, they are more prone to becoming abscesses. So you can see this child has 2 here and And this, again, kind of is a nice summary of some of the features that would be a tip-off for me from a skin standpoint to be concerned about autosomal dominant hyper-IgE syndrome. So again, just another look at this papulopustular eruption. You can see the erythema surrounding it and these individual papules and pustules that, again, would be a little bit atypical for atopic dermatitis. Here you can see, again, the same idea that the distribution is kind of now hedging into the buttocks. It's a little bit more like Kinna-5. There's lots of erosions. And the thought with this is, when you look at atopic dermatitis, it's scaly. You have some of these chronic changes from itching, but with this, what we think is that the pruritus associated with hyper-IgE syndrome leads to those changes that, on first glance, just appear to be atopic dermatitis-like. But on closer look, if you really look for these individual discrete lesions, that might be the tip-off for you. Of course, facies, what we mean by that is if you look at patients, and typically it's more apparent in adults, although it can begin in childhood as well, they have almost like a doughy consistency to the skin on their face. So when you look at this woman's nose, she kind of has like a more bulbous nose. You're not getting a great up-close look, but pores are often more open and dilated. So that's sort of it's a look where you look at someone and you can't quite put your finger on what seems different, but it's usually a reflection of like a more bulbous and textured appearance to their skin. And then down here, what we have is an example of a high arched palate, and these are two examples of hyperextensibility. This one is probably apparent to anyone who think, wow, they're double jointed, they can move their fingers quite well. This is something that we also use to diagnose Ehlers-Danlos syndrome. So it's something called the Gorlin sign. Most people cannot touch their tongue to their nose, but if you can do that, that's an indication of hyperextensibility and can be associated with autosomal dominant hyper-IgE syndrome. Okay, so switching gears a little bit, when we talk about autosomal dominant, the STAT3 mutations in hyper-IgE syndrome, it's important to consider the other forms of it as well. And so from autosomal dominant perspective, the one that we are most familiar with in dermatology is the DOCK8 deficiency. And these typically present to us with really severe and widespread viral infections. So what we have an example of here, these are all just verruca vulgaris. And so these are just really extensive, just plain warts, or sorry, not P-L-A-N-E, but P-L-A-I-N, just regular run-of-the-mill warts that are, you can see just the extensive involvement all around the fingertips surrounding the nails. And this would be atypical for something that I would just see in a normal patient. Here, these are all molluscum lesions, and looking at them, if you can get up close, they have this very classic look where there are these umbilicated flesh or red papules, but just the severity of the dissemination is a clue this is not totally normal. And this is the dermatitis that goes along with DOCK8 deficiency. So the dermatitis here is considered to be more atopic dermatitis-like, so more scaly, obviously very pruritic. This child has been scratching himself from head to toe, but very widespread, very severe. This is just an example of herpes gingivostomatitis. So again, these children don't just get a cold sore, they get just a fulminant oral disease that what these represent, you can kind of see a little bit of like a vesicle here, or ulceration here. So nothing when it comes to viral infections with these children is subtle or mild. I just wanted to show again, for example, you may or may not see molluscum on a regular basis in your clinic, but I see it all the time. And again, I think it's just important to know, and this was a bar that I had to reset for myself when I first started seeing patients or seeing children as a resident. This is pretty run-of-the-mill or mild molluscum. So sometimes you have a patient that comes in with one or two. This is a little bit more common where you have some actinated grouped papules that have that classic look where they're pink with the central umbilication. But having a handful, even up to 50 or so, would not be irregular, as opposed to this patient here who has them completely widespread. Similarly, this is just a child without any sort of immunodeficiency with warts on their hand. This is run-of-the-mill for me. So when I see this, I'm like, okay, like you just have warts. And again, I remember asking my attendings when I first started training, I was like, that seems like a lot of warts. Like, do you worry about immunodeficiency in these kids? And they're like, no, that's pretty normal. But again, that's a stark contrast to to the individual's fingertips up here on the left. So that's something that for me is was an adjustment that I had to make to not worry that if you have more than a couple that all of a sudden everyone has an immunodeficiency. But kids can get extensive disease, but it's never quite the same as what you're seeing in DOCK8 deficiency. One other important component of DOCK8 deficiency, Hyper-IgE syndrome, is that they're more prone to cutaneous malignancies. So cutaneous T-cell lymphoma is one of those manifestations. It's not so super common, but squamous cell carcinoma as well. And I just want to put a couple examples of this up for you, because that's something that you might see in clinic if you're following any of these patients, especially adult ones. So when we're talking about squamous cell carcinoma, it's something that appeared de novo, again, usually in some exposed sites because UV damage leads to or promotes squamous cell carcinoma growth. And the characteristic look for this is, in addition to sort of being pink red, is that they have a lot of crust with it. And sometimes if these lesions become more progressive, then they can ulcerate and break down. So this is one that we would consider just an outright squamous cell carcinoma. This one, when you look at it, it's a little bit harder to know for sure. This, on biopsy, was a squamous cell carcinoma in situ, so it was not invasive, and that's why it lacked some of the other more impressive appearances of this. When in doubt, I think it's just important to kind of keep an eye on it. Most things, when it's just like a run-of-the-mill rash, you're not really sure, it'll go away in a couple weeks. If it's something that's progressive and stable, and you have concerns about it, send them to a dermatologist, and we can biopsy it and know for sure. But again, the erythema in the scale and some superficial erosions, and in later stages, ulcerations are things that you want to look for to keep in mind squamous cell carcinoma. Any questions about any of these?
On the Hyper-IgE, is anything unusual about their biopsy just pathologically? Is there mast cell activation or
nothing you can see? I mean, there's the look is more sort of like a spongiotic dermatitis. So I don't think that a biopsy is typically helpful to distinguish between the two. It's more the clinical look to them. So, and when I say spongiotic dermatitis, when you're looking at the upper layer of the skin, it just means that there's edema in between the different keratinocytes, and then you'll see like a lympho/eosinophilic infiltrate in the dermatitis. Okay, so moving on to other forms of Hyper-IgE syndrome. So Phosphoglucomutase 3 is another cause of Hyper-IgE, autosomal recessive, and this is a disorder of glycosylation. And the thought is some of the products that are made through glycosylation are important in different signaling pathways, leading to the clinical phenotype. So similar to DOCK8 deficiency, these patients have more of a severe atopic dermatitis, and then they're more prone to other atopic things like asthma and seasonal allergies. Scalp and folds in the face are common areas of involvement. They also have recurrent infections, so similar to all Hyper-IgE, they have recurrent sentinel pulmonary infections, but are more prone to having staphylococcal skin infections, pneumonias. I mentioned this in parentheses here, the pneumatocyl, I think, from a pulmonary standpoint, and maybe your standpoint, we used to think of pneumatocyls as pathognomonic for autosomal dominant Hyper-IgE syndrome. It turns out that it's not the case because this can present with it as well. They are prone to viral and fungal infections as well, but definitely not to the same degree that autosomal dominant Hyper-IgE is prone to fungal infections, and DOCK8 deficiency is prone to viral ones. The autoimmune symptoms are an important characteristic of Phosphoglucomutase 3 deficiency. So these patients are more prone to hemolytic anemia and hepatitis. And then what I have here in bold is CSVD, or cutaneous small vessel vasculitis. That is something that we think is very specific to this particular etiology of Hyper-IgE syndrome. And I'll show you some pictures of what that looks like. There are also reports in the literature of what's called erythema multiforme major. As a dermatologist reading articles from the immunology literature, it's hard to know if that's something that was a dermatologist diagnosis or something that we think, oh, that's the best example that we can give, and this comes up kind of all the time. And why I think it's really important to have dermatologists involved so that we have sort of like a standardized nomenclature when characterizing these patients. But I'll show you an example of what EM major looks like as well. But these are basically a rash that is more prone to be seen in the infant and early childhood ages in patients with this deficiency. And then another sort of hallmark of the phosphoglucomutase 3 deficiency is that they have neurologic problems as well. So developmental delay, ataxia, myoclonus, hearing loss, seizures. So if you see a patient with hyper-IgE and some neurologic problems, that's, again, something to be thinking about. And then they similarly have dysmorphic facies. The look to that is a little bit different than the ones that we think of for autosomal dominant hyper-IgE syndrome. And I'll show you an example. And then scoliosis. From the immunologic standpoint, they are lymphopenic for CD8 positive T cells and memory B cells, and they are skewed towards a Th2, Th17 phenotype, which maybe is not surprising, leading to elevated IgE levels. So this is a paper with a cohort that had phosphoglucomutase hyper-IgE syndrome. And what we're looking at here is just an eczematous eruption on the back that responded really well to topical steroids. Again, it's a little bit hard to get into the granularity of this. This is just a more classic sort of scaling erythematous rash and not the individual papules and pustules. But the facies you can appreciate a little bit here. So these patients, as opposed to the autosomal dominant hyper-IgE, have more sort of protuberant lips. And their nostrils are flared and wide. So they have a look that, too, is maybe a little bit atypical. And one thing that's nice for me is often when I see my patients, their parents are with them, so I can say, hey, do you look the same? And if you're never not sure, you can say, hey, does little Johnny look more like mom or dad? And that's kind of a nice way of asking if they don't look totally normal. And and that can be helpful as well. So that's what we're looking at.
What was the after? What was the treatment?
Oh, so this was just with respect to the dermatitis that he had here on the...
Before and after an intervention, or just...
Oh, yeah, sorry, the intervention was just topical steroids.
Just, okay,
yep.
Topical steroids, all right.
So, and this is just an example, again, of cutaneous small vessel vasculitis, not in a patient who had phosphoglucomutase 3 deficiency. But when I make that diagnosis, again, what I'm looking at here is that the primary characteristic of this rash is that it's non-blanching. So you'll have these individual, very small patches of bright redness. As they age, they become a little bit more purple, and then they fade the same way that, sort of like the same colors that bruises do, sometimes leaving behind a little bit of dark hyperpigmentation. But when you press on this, nothing changes, and that's really important. If you ever see this, from my standpoint, whenever we see vasculitis of the skin, of the small vessels there, we worry about small vessel vasculitis in other places as well, and the one that we care most about is the kidney, so just checking UA and considering if UA and creatinine is important too, just to make sure that these children aren't having renal effects as well. And then this is an example of erythema multiforme major. That's a character or a term that's going a little bit out of style these days. But in the context of this paper and the reports on phosphoglucomutase 3, normally what we refer to is a erythematous, kind of like widespread bullseye-like eruption. So true erythema multiforme has 3 individual spots, and there's a dusky center, and then a white rim around that, and then a red rim. So there's 3 individual spots, so it looks like a true bullseye. And the designation of EM major is that you also have some sort of mucosal surface involvement, most commonly the eyes or the mouth. So that's why it's a little bit hard for me to interpret what they mean by an erythema multiforme major, because they didn't mention that there was any mucosal surface involvement. But in general, this is sort of the look that you might expect with these ulcerating, large annular eruptions. Again, this is not a classic erythema multiforme bullseye, but this would be in the context of a blistering or eroding eruption. So if you see something like that early on in childhood in a patient with hyper-IgE, I would consider phosphoglucomutase 3 deficiency as well. And then there's been 2 reports of TYK2 deficiency leading to hyper-IgE syndrome. TYK2 is a member of the JAK-STAT signaling pathway, and these patients have a defect in IL-12 and TNF signaling, so that predisposes them to mycobacterial and intracellular bacterial infections, in addition to the high IgE levels, the recurrent sinus pulmonary infections, and they too get more frequent viral infections. They do not seem to have any of the other sort of skeletal or dental defects that we see in some of the other forms of Hyper-IgE syndrome, but they too get an atopic dermatitis-like eruption, skin abscesses, and thrush. I don't have any pictures of this because all the reports of this were actually in immunology journals, not clinical journals. So I hope this is a handy chart that you can refer to if you ever need to. Again, I think when you look at the Hyper-IgE syndromes altogether, they're unifying characteristics of that they all have eosinophilia and high IgE levels, as well as recurrent sinopulmonary infections. And the way that I would kind of help distinguish them from each other with respect to the autosomal dominant, again, you're going to see the very characteristic facies. They'll ask about primary dentition and retention of that, the high arch palate, the bone fractures, the joint hyperextensibility, and they are more prone to be getting the fungal infections. As opposed to DOC8, which is really characterized by a severe atopic diathesis, so in addition to having more extensive and severe atopic dermatitis, they're more prone to having allergies and allergic rhinitis. They are more prone to having viral infections, and then they have this risk of malignancy. With phosphoglucomutase, similarly to DOC8 deficiency, they also have the atopic diathesis, but there you're going to be looking for the small vessel vasculitis and the neurologic symptoms. Down here.
How does a high IgE play a role in the pathology here?
I have no idea. That's a really great question. When I think about high IgE, I think in terms of like we're skewing towards more of a Th2 response. But honestly, I don't know why it works the way that does. And then with the TYK2 deficiencies, you're just looking at the viral skin infections, and they sort of have a more variable phenotype, but lack a lot of the other characteristics that distinguish these. All right. So I really like this slide. When I got my PhD in immunology, I worked on hematopoiesis, and so I like transcription factors because it's something that I understand. And looking at at this sort of schematic of the things that are involved in T-cell lineage fate decisions, this is, I think, kind of a nice bridge, because when we are talking about Hyper-IgE syndrome and STAT3, what we know is that these patients that have Job syndrome or autosomal dominant Hyper-IgE syndrome, they lack the Th17 compartment, and that's because you actually need STAT3 for the genesis of Th17 cells. And one thing that I think of as sort of like the counterpart of this is if we move this way and we have STAT1 pushing us more towards a Th1 phenotype, that too will result in less Th17 cells, and what we know is that STAT1 gain-of-function mutations are one of the causes of chronic cutaneous candidiasis. So let's switch gears and talk about this now for a little bit. So the sort of classic CMC is, again, a STAT1 autosomal dominant gain-of-function mutation. In addition to getting the candidal changes, these patients are more prone to other fungal infections, as well as mycobacterial and bacterial infections, again, sinopulmonary ones. They are more prone to herpes infections and autoimmune diseases, things like autoimmune hepatitis, diabetes. Basically, you name it, they can get autoimmune disease, even though we don't often think of that as one of the consequences of having this mutation. There are other causes for chronic cutaneous candidiasis now that we know of as well. Dectin-1 is a pattern recognition receptor for beta-glucan on the surface of fungus. And these patients are more prone to getting vulvovaginal candidiasis and then esophageal candidiasis, but all of these candidal infections remain superficial, so none are invasive and they're not prone to other fungal infections. That's in contrast to CARB9. So this is a signaling molecule that's downstream from dectin that can predispose to, so deficiencies of these predispose to superficial candidiasis, but also invasive candidal and germanophyte infections. And then we have the whole sequence of IL-17 related genes, including the IL-17 receptor alpha and ACT1, which again is a scaffolding protein that's downstream from IL-17 receptor alpha, and then IL-17F. So there's multiple different isoforms of IL-17 that contribute to its signaling. When we look at these, the IL-17RA and ACT1 are autosomal recessive, and in addition to getting the candidiasis, these patients are more prone to getting bacterial infections of their skin, whereas the IL-17F, they really only have the candidal infections. So let's take a look at what some of these infections can look like. So this is a patient with STAT1 gain-of-function mutation who presented was totally normal until about teenage years, and then developed these verrucous plaques on the feet. And when a dermatologist sees this, like, we think about fungus, but that's about like 3 or 4 in a differential. We're just like, wow, like this looks like some crazy like malignancy, some other like fungating infection. So all bets are off when you see a presentation like this, because anything could be lurking underneath there. But certainly we would all be worried about some sort of immunodeficiency. I had a patient who was HIV positive who had a look not too dissimilar from this, who had both Kaposi sarcoma and a coccidiomycosis infection in the same lesion. So anything like this could be a nice mixture of things. So originally the authors of this paper, they thought this might be a really extreme like form of psoriasis or psoriasiform dermatitis. They did a biopsy that did show some fungal elements, some bacteria as well, but a lot of the very characteristic looks of psoriasis under the microscope. And so they tried treating her with anti-inflammatory therapies, including an anti-TNF, monoclonal antibody, and so when they did that, she went from bad to worse. And then as they were coming to the conclusion about what she had and doing recurrent biopsies and cultures, they ultimately came to the conclusion that she had CMC and treated her with a 2-month course of terbinafine, and as you can see, everything melted away. So this is all just with antifungal treatment. This represents her father, who had the same mutation, and looking at it, the improvement is a little bit less impressive. That being said, if a patient came to me like this, certainly psoriasis would be more likely on my differential diagnosis. This is something that I think that any dermatologist would be like, yeah, psoriasis is probably the most likely diagnosis. Maybe it's a fungal infection. But this is pretty extreme for just sort of run-of-the-mill tinea pedis. So for me, if I were to be like, oh, this ends up not being psoriasis, then I need to be thinking that this is a little bit more than just, hey, I got athlete's foot when I was at the gym, in the shower. So, but similarly, when Dad got terbinafine, you can see that sort of like the crusting that goes along with it was much improved. So I think it's also important to kind of talk about the characteristics of tinea pedis. So what we described this is the Moxon distribution of tinea. So oftentimes when we think of athlete's foot or tinea pedis, we're thinking about like the macerated, gooey, web space infections. But often it's just kind of some erythema, often with scale. Sometimes it gets a little bit more exuberant, but it kind of just limits itself to the bottom and the sides of the feet. So it's just another form that tinea pedis can take, and important for you guys to keep in mind as well.
How long did you say the evolution of those toe lesions was? Is that
so that was over the course of years. So, but the improvement was over the course of months after starting.
So people let that go for years before they came to the doctor?
You'd be amazed at some of the things that people let go for a long time. So, I without like knowing this patient myself, if I remember from the report correctly, so this was her in her like late 20s, and things started in her teens, and they're like, oh, like kind of treating it didn't seem that bad, and then slowly with time, as things go slowly, you pay less attention until it's there. But you'd be amazed things that I see in the dermatology literature about people who let their like basal cell cancers just go on for years and years and years. And a lot of times patients don't come because they're embarrassed by it, and so they're like, oh my gosh, like this is so gross, I don't want anyone to see it. And it's a lot of fear, either of what the diagnosis is or embarrassment of how it looks, that precludes them from seeking medical care. So, and sometimes it's also just access and finance and all those other sorts of things. But this unfortunately happens more frequently than you would hope. So I just wanted to bring up another example of squamous cell carcinoma here. So this is, and this is something that you could see in the DOCK deficiency that we had talked about too. So this is one that's been going on for a longer time too. you can see that it's just almost this like mushrooming mass. It's red. It's kind of like you see like this rim kind of like crusting and scale. It's eroded. So this is one that would be very advanced by the time that's biopsied, and we'd expect that it's invading deep as well. And the reason I bring this up is because you can look at this, and you can look at this and think, oh gosh, like that could just as easily have been a squamous cell cancer. And in the context of infections that continue to elicit an inflammatory response, so when you have extensive HPV infections, oftentimes they can become squamous cell carcinoma. So it's just important to think about too. So, for instance, if the patient improved in C and there was still anything left over at the end, I would have biopsied that to make sure it wasn't a squamous cell carcinoma. So it's just important to remember that lots of these things can exist simultaneously, especially when it's been ongoing for years before someone seeks medical attention. And to try and triage, take the biopsy, look for areas that just seem a little bit different, a little bit thicker, more ulcerated, just make sure there's not a secondary pathology within the primary one. But I think, again, from this case, I think they ended up taking 5 or 6 biopsies before they kind of got to the point where they did all the genetic testing and realized what was actually going on there. This is just another example of Cutaneous candidiasis. This is, again, a STAT1 gain-of-function mutation. And you can see here that this patient has pretty extensive candidal paronychia. So paronychia is just referring to inflammation around the nail beds. The most common cause of acute paronychia that we see is staph infections, but you can have sort of a low-grade chronic one that's a little less symptomatic, so patients often don't seek care. That's candidal and can involve multiple nails. So if it's ongoing for a long period of time, people are it's I've always kind of had a little bit of inflammation around there, and now my nails are growing in funny. Think about Candida as the etiology for that. And this is just some thickened plaques that showed hyphae on scraping. That's consistent with Candida, and this is just a little candidal infection here. So this case report I thought was really interesting because when we think about CNC, and I mentioned that they have autoimmune disease as well. So there's a patient who had alopecia areata in addition to the mycoses associated with her STAT1 gain-of-function mutation. And there's a medication that they use for rheumatoid arthritis now that maybe you guys use as well, ruxolitinib. And it's a STAT1 inhibitor, so it's a JAK-STAT pathway inhibitor. And what they found was when they gave that patient ruxolitinib, all of her alopecia regrew, and all of the signs of her Cutaneous candidiasis went away as well. So it's something to think about as well. Treating an infection with an anti-inflammatory agent might be useful, so it's something to keep in your back pocket. Okay, so I'm going to move on to APSED. How am I doing on time?
About 15 minutes.
Okay. So with APSED, we think of this as a polyendocrineopathy that's related to deficiencies in air that helps us maintain central tolerance for T cells during chronic education. The classic triad for this is chronic mucocutaneous candidiasis, hypoparathyroidism, and Addison's disease, and patients need to have 2 of 3s to make the official diagnosis. Again, with the CMC, they have diaperdermatitis, or more superficial vulvovaginal candidiasis. They can have esophagitis, oral thrush, then the paronychia, non-onychomycosis, or the fungal infection of the nails that we've been discussing. These patients are also more prone to getting vitiligo and alopecia areata, so 2 diseases that I see pretty frequently, and then urticarial eruptions. Other signs that you can see just looking at them, dental enamel hypoplasia, so you might see some pits in their teeth. Keratoconjunctivitis, where they might end up having some bloodshot eyes or looking at their eyes, and then nail dystrophies. And the nail dystrophy, we think, is likely a combination of either fungal infections or the inflammation that just goes around the nail bed, where the dental enamel hypoplasia could be a combination of infections and fungal infections as well as having decreased calcium because the patients are hypoparathyroid. And then one other thing that's not often noted is that these patients can also get a Sjogren syndrome, like salivary gland inflammation, so they have dry mouth, and that can be something to ask about as well. So I want to point this article out to you guys, so I thought it was really interesting. So this was a group who proposed sort of like a reclassification of the criteria for APSED. So in addition to the classic 3, they also mentioned sort of like a GI disruption. So not a true like gastroenteritis, but some problems with the GI system, as well as a bullous or an urticarial-like eruption and the dental enamel hypoplasia as 3 more criteria to involve in this diagnosis, and then to get 2 of those 6 instead of 2 of those 3. When they look back at their patient cohort, and this is all an American cohort, this came out of the NIH, what they found is that a lot of these patients presented with some absorption problems and this urticarial eruption, and if they used those as part of the diagnostic criteria, they made the diagnosis of APSED on average 4 years earlier, so at 3.5 years instead of 7.5 years. And it presented about half. It would have presented about half the patients from presenting with Addisonian crises. And so, from a overall health standpoint, that's great. I think the flip side of it is I don't know how many patients you would pick up that might have 2 of these that do not end up having some false positives with that. But it seems like it's at least worth thinking about these criteria if you're ever evaluating a patient who is suspected of having APSED. So, looking at this is their example of an urticarial eruption. And urticarial it's a kind of a difficult term because what we're trying to get at with that is that it's raised and it's red. It kind of looks like urticaria, but it's not quite true urticaria. And so basically if you have a raised red eruption that does not have a lot of secondary skin changes to it, that's a pretty good approximation for urticarial. And that's as opposed to true urticaria, where you can see that there's sort of this is with the central clearing. You can see that this is like a polycyclic plaque that's not resolving. Over here, this has a little bit more of the classic look for urticaria, where you have the raised red edge. The center can be a little bit more edematous and can vary anywhere from sort of like almost white from the intense edema underneath to a pinkish look to it, and again, kind of polycyclic and the individual lesions running into each other. So again, this is one of those things that I think with time and when I've seen enough of it, it makes a little bit more sense, and I might not be able to convey all the nuances in a 1-minute slideshow. But here maybe you can appreciate that the look isn't quite the same, that these lesions are a little bit more individual. They're not kind of blending into each other quite as well or as in a polycyclic form. And the surrounding sort of like vasoconstriction or the extra erythema around the individual hives is not present in these lesions. So these, again, some other dermatologic manifestations of APSED that we talked about. So thrush, this is a great example of chronic candidal paronychia here. So you can see that the nail fold is completely inflamed. You think this would be super, super painful. It's uncomfortable, but it's not the same pain that you would experience with bacterial paronychia, where there's something to drain. But you can see that multiple toes are affected. What this is demonstrating is the poliosis associated with vitiligo. So vitiligo can often present in the scalp as individual lesions of just stark white hair. This can also be a preceding sign of alopecia areata. So it wouldn't surprise me either if this is one where, within the next few months, the hair completely fell out in this area. And then what's going on here, this is a halo nevus, and this can also be an early sign of vitiligo, where the immune reaction is directed at the melanocytes because they have an increased amount, or at the nevi because they have an increased amount of melanocytes there. So, okay, we're going to wrap up with a few straightforward. Well, I don't know if anything's straightforward.
Is there a new treatment for vitiligo? Really?
Yeah. So for vitiligo, we use tofacitinib. So a lot of these JAK-STAT things seem to be really helpful for alopecia areata and vitiligo. In adults, they are now in the process of getting them FDA approved. So I think they're like undergoing clinical trials. I had a patient in residency who was 16 who had alopecia universalis. So she was a young woman that had zero, absolutely no hair. We put her on tofacitinib, and within the first few months, all her hair started to grow back. I mean, the actual genesis of your hair growing back will still take a while just because the hair needs to grow, but it seems to be really effective. I think the issue with it is that we're finding now that as these patients, we try to taper them off medication, everything comes back. So,
is that the same one that causes bald men to get their hair back when they get this for chemotherapy? Because there's a monoclonal that restores hair completely and then they're bald.
That I don't know. I haven't heard about that, but it could very well be. So there are different. Yeah, I mean, there are epidermal growth factor receptor inhibitors, so EGFR, that cause hypertrichosis, but usually they manifest as eyelashes that are out to here, and hair in other places. So I haven't heard reports of it actually regrowing, but it could very well be. So GATA2 is a transcription factor that's important for hematopoiesis, specifically for monocytes, neutrophils, and NK cells. When you have GATA2 deficiency and the clinical phenotype associated with that, it's an autosomal dominant inheritance that's characterized primarily by warts, immunodeficiency, as we mentioned, lymphedema, and frequent infections, and then sometimes sensorineural hearing loss. So again, these patients will manifest with frequent soft tissue infections, and they'll have really recalcitrant warts. And as a result of that, oftentimes they end up getting squamous cell carcinoma because these warts are left untreated or inadequately treated. Other skin things that I would see with this deficiency that have been reported are inflammation of the fat, so just kind of general funiculitis, specifically erythema nodosum, where you get these tender individual nodules that are red on the tibial area, and then sweet syndrome, which is a neutrophilic dermatosis that's characterized by, again, very similar, just round, almost plum-like nodules that are on the skin and can sometimes be tender as well. And then, again, lower lymphedema. So one of the things about this immunodeficiency is that it usually doesn't present until later in life. So patients are in their late teens, 20s, sometimes even their 30s before all of these manifestations start to pop up and people kind of put the pieces together. This is a case out of the NIH of a patient with GATA2 deficiency, and you can see that she has warts. Maybe a little bit hard to appreciate, but lots kind of here in the periungual area. You can see a couple here, but lots of her digits are affected. And in addition to that, she also had lower extremity lymphedema. So looking at this is something that was pitting. You can see that someone placed their thumb there, and the edema was present. So this combination should really raise your suspicion for it. The lymphedema is not uniformly present. It depends on what the mutation is in GATA2. So the GATA2 is also expressed on lymphatic valves, and so that leads to lymphedema. And there's some, if it's a loss of function entirely, then these patients will get lymphedema, but if it's one that was just like a missense mutation, they often do not have that. But looking for disseminated mycobacterial infections that might be related to the loss of monocytes and macrophages is another important clue to the diagnosis. This is a patient who presented with disseminated HSV infection. So again, these patients have a hard time with viruses as well, primarily because they have a reduced number of NK cells. So that's another thing that can present with GATA2 deficiency. That didn't work quite as well. All right, so and then
any treatment for GATA2 or
stem cell transplant.
What?
Stem cell transplant.
How do you treat the warts when people have this many
Yeah,
warts?
so that's a great question. So we haven't talked about that, so thank you for bringing that up. So warts, when they're localized, biotherapy works really well. Often these patients, that's not going to be enough. Doing things like 5-fluorouracil, so like a topical chemo agent under occlusion can help. We now have sildenafil, which is an antiviral. It's a nucleotide or nucleoside inhibitor. Works really well for these as well. We typically start with topical because we don't think that there's side effects that go along with that. But just thinking back to residency, and I didn't have any immunodeficient patients who had it, but I had many patients with HIV who had extensive warts, that you can give that IV as well, and that it works. It's pretty nephrotoxic, so you have to be really careful about administering. But for the warts, typically they will need something that's a little bit stronger than just like salicylic acid, like compound W and freezing. But to localized areas, trying freezing would be completely appropriate. So.
What's the name of that?
Sildenafil. CIDOFOVIR. And there's a compounding, so that's something that needs to be compounded. We have one in Philadelphia that we work with, but I'm sure there are other ones in the country. And I believe it's a 2% compounded that we put on twice a day. So for IPEX, this is a deficiency in FOXP3 that's required for T regulatory cell development. So the hallmark for this, and this is one of the things that I see with Suzanne and Troy a lot, is just this eczematous dermatitis. That's the most common presentation, often on the lower limbs and trunk of the face. Sometimes it can progress so much that these patients are just red from head to toe, and sometimes have a dermatitis that looks more like psoriasis. They often get urticaria, blisters, inflammation of the lips, including swelling from some of the allergic phenotype that they can get from this as well. They'll have nail changes and then autoimmune So this is a nice example of a child with IPEX, who you can see everywhere just has these red, scaly, here I would consider these to be more psoriasiform, just because you have these thicker plaques that have a nice silvery white scale across the surface. As opposed to here, where you might think that these are a little bit more eczematous changes, just because the sort of the superficial scale and they're a little bit more flat and less well circumscribed, goes along better for an eczematous eruption. And then you can see this child has pretty significant chylitis. This is, again, another example that's a little bit better for a psoriasiform eruption. So this child has these plaques that are on the knees and in the groin area, where it kind of has like a pink reddish look to it, and then this nice silvery shiny scale over the surface. This is something, this longitudinal ridging of the nails is something that we call tracheonychia, which represents inflammation that's involving the nail matrix, where the nail plate is made. So this is just a reflection that there's all this sort of, the inflammation that you're seeing in the skin up here is also occurring down here in the matrix. And then this is, this patient also happened to have alopecia universalis. And again, something like the tofacitinib is something you could consider for this. But I know here, fellows can kind of speak to that, we transplant the majority of these kids. And the thing that's interesting is that for these refractory dermatitis, people have tried everything, cyclosporin, mycophenolate, basically anything that you can throw at them, and nothing seems to work. So topical steroids are the mainstay until you can get them to transplant. Even oral prednisone does not seem to help. Okay, last one, really quickly. So this is something that we know about in dermatology that I'd never heard of before. This PLAD, or PLCG2, antibody deficiency and immune dysregulation. So this is characterized by autoimmunity, atopy, an IgA and IgM immunodeficiency, as well as an NK immunodeficiency, where they all have sinopulmonary infections. And then they have abnormal neutrophil chemotaxis and TNF-induced activation. But interestingly, the neutrophils and the monocytes, when they are activated, at lower temperatures, they're more prone to getting activated and have an exuberant response, which leads to their clinical phenotype. So the dermatologic manifestations is that these patients get cold urticaria. So whenever they are in the cold, and specifically it's more with evaporative cooling, or you're just like immersed entirely in cold water. When they're young, they will get sort of like a splotchy redness to their skin, and it's itchy. But the thing that distinguishes it from sort of run-of-the-mill dermatitis is that it has a burning sensation to it, which is a little bit atypical. And this is thought to be a function of enhanced mast cell signaling at the colder temperatures in patients with this deficiency. Some of these patients that develop this splotchy erythema in infancy also have nasal tip ulceration. So these areas of our body, the acral sites that are cooler, are more prone to ulcerations. It's interesting that the ulceration only happens at the nasal tip, but if you look at the patient's fingers, they often have some erythema and some blueness, some acral cyanotic changes. And then cutaneous granulomas is a hallmark of these patients in adulthood. And interestingly, they appear to spare the skin folds, which we think is a function of the fact that those areas are warmer. So this is an example of PLAD. Really impressive that you can see this infant, the nasal tip just is completely ulcerated off. And here, fortunately, it was able to maintain the shape when things healed. But again, there's not a whole lot we can do about this except try and keep the child as warm as possible. And these are the cutaneous granulomas. And again, like very, very striking how widespread this is. And for granulomas, and this is something, again, that it's a whole other talk that we could have. There's so many immunodeficiencies that present with these granulomas that are non-infectious that we don't know exactly why they happen. But the hand-waving answer is there's some immune dysregulation that allows them to form. But something like this, I would always want to make sure there's not an infection brewing underneath. This could be about 5,000 different things that I see in dermatology, none of which are good. But it ended up just being a granuloma in the context of this patient with PLAD. Oh, I guess you're cutting me off. Anyway, it's 8 o'clock, so that's my cue. But the treatment for that too, so the thought is moving to a warmer climate seems to be the only thing that helps. They, again, have tried lots of immunosuppressive things, even anti-TNF agents that don't seem to help. Oral prednisone will give like a partial response, but not clear it. But again, the risks of having long-term prednisone therapy is not ideal either. So, a difficult thing to treat. All right. Any questions?
Amazing.
the nose came off, do they have cryoglobulins or cryofibrinogens as
I
part of that?
so I don't know if people have looked for that, but my guess would be probably no.
Probably looked and didn't find it.
Yeah. So the reports that I've read didn't address whether that anyone's ever looked for that.
Wow. So, we need to send more people to you.
I would love it. Yeah, please do. Please
In the Hyper-IgE patients, have there any case reports of anti-IL-5 or anti-IgE?
do. Yeah, so I haven't seen anything about that yet. But, that or the olimizumab would be interesting to see.
I think that'd be useful to try.
Yeah, I mean, especially for the inflammatory manifestations. I think a lot of it, because the STAT3 is involved in so many different things, like the primary, the routine primary teeth and the scoliosis and the bones and fractures like that has to be like some separate thing that we can't probably fix out. But yeah, I mean, if part of the reason that we're getting these frequent eruptions and the infections again, like is the infection like is it just because we're doing too much to teach two instead of teach one? It's hard to know whether using those agents would modify the entire immune system enough to kind of like push it back.
Seems like it'd be worth a try though.
Totally.
You guys need help cleaning this up? I don't know who brought this today. You want to take it with you to the office?
Well, I'm not going back to the office. Usually Len takes it back.
I didn't bring
No,
those.
I didn't either.
Somebody.
I'll help
I know
you guys clean up.